Hey guys, let's talk about Parkinson's and get this semester knocked out. Last topic that we have to cover. So we'll go ahead and get started. I'll go to share screen and let's get after it. Finish up strong. We got this. Here we go. So let's talk about exercise for people with Parkinson's disease. I've had it in my family. I've seen several people in my family that have suffered from Parkinson's disease. And so I've seen it firsthand, and I see a lot of the things that are talked about in this chapter. So exactly what is Parkinson's disease? It's progressive, it's neurodegenerative disorder. It results from damaged and abnormally functioning neurons in the areas of the brain responsible for movement. So think about that. Progressive, that means it's going to continue to get worse. Neurodegenerative, when something is degenerative, it is breaking down your nervous system, basically. You've got abnormally functioning neurons in the areas of the brain that are responsible for movement. So you may want to move a certain way, and at a certain point in Parkinson's disease, you'll be unable to do that. It's a sad progression that you see, actually. Subthalamic thalamic nuclei. What is this? They're located in the midbrain. I'm not going to go through that all those words. You would get dizzy, and so would I. Contain most of the dopamine producing neurons in the brain. Okay, that's something to know. Along with the globus pallidus, it acts as a pacemaker for the basal ganglia. So what happens, your basal ganglia, subthalamic nuclei, and substantia nigra help initiate and facilitate desired movement and inhibit competing movements, and that helps us have efficient movements. So when you're having issues with these three things working together, then you're going to start having some of these competing movements getting in the way of the desired movements that we want to do. So you'll be trying to reach for a cup and you may overreach. It's the tremors that you start seeing in the first steps of Parkinson's. These are undesired competing movements that start happening in the body. As far as symptoms of Parkinson's disease, tremor, bradykinesia, muscle rigidity, postural instability, and gait disturbances, especially as it starts to progress along. Let's talk about these. So there's a progression of problems with walking or problems with the gait that you see in people who are dealing with Parkinson's. First, you're going to see the arm swing, normal arm swing when you walk, become disrupted. Then steps. Now this is moving down and getting worse, as you see. It's a continuum. Next, your steps will become slower. Then your steps become smaller. Festination may develop, which is where you actually get stuck. You'll see this in patients who have Parkinson's. They're trying to move, but they can't for time periods. Tendency to propel forward develops. So it's like you're stuck, and then it's this forward lean and kind of a fast movement, which is not really safe. Freezing, like we said, may develop. Some non-motor symptoms of Parkinson's disease: anosmia, sleep disturbances, fatigue, mood disorders, orthostatic hypotension. Orthostatic hypotension has to deal with changes in blood pressure, usually a drop in blood pressure, depending on the position of your body. Fatigue is very common in this group, as are mood disorders. I would have a mood disorder too if I was trying to pick up a pen, and I've always been able to do that, and now I can't do it. I'd be pissed off, and I'd have a mood disorder also. So just something to think about. Dysphagia, trouble with swallowing, difficulty with voice projection. The voice tends to get weaker as Parkinson's disease continues to become worse. Micrographia, if you don't know what any of these things are, go through the chapter, find them, and write down what the definition is. That's part of the learning curve of this class. Bladder difficulties is showing up again, and constipation. Risk factors for Parkinson's disease: age. As age increases, the risk goes up. A family history. Sex plays a role, more common in men. Environmental factors are what sort of things have you been around that may have affected your the areas that we talked about earlier. And genetics, again, which is family history. There's also a genetic predisposition that can be found in like the RNA, DNA of people who have Parkinson's. And that's where you see people doing research to try to figure out how to actually cure things. When you start finding genetic factors and certain things that can be targeted, that's when you're starting to make some progress. Some genetic risk factors: alpha-synuclein, Parkin2, PINK1, LRRK2. We'll talk about these. Environmental risk factors. They have shown there to be a higher incidence of Parkinson's disease in developed countries, rural areas, agricultural and industrial work sites. So that tells me that there are some kind of like carcinogens, are things that we are exposed to that can cause you to have cancer. These are parkinsinogens, things that we are exposed to in industrial work sites and cities and farm communities that can predispose you to Parkinson's disease as well. There's early onset Parkinson's disease where you're diagnosed under the age of 60. When this happens, usually you see a slower progression of the disease with a lower rate of dementia being part of what you're dealing with, increased dyskinesia in response to the L-DOPA treatment. So you're able to function better when you have early onset Parkinson's disease. The initial symptoms, things that you would never really think of: abnormal arching of the foot and toes. I've had foot cramps that is kind of similar to that. Wouldn't think, oh gosh, Parkinson's disease is coming on. And that's a good thing that you don't jump straight to that. Now this next part, this is kind of telltale to me: involuntary limb movements and possibly tremors. If I started having those things, then yes, I would start, that would be something that would enter my mind because I've seen the tremors. According to Hahn and Yar, there are some stages of Parkinson's disease. Stage 1 is the lightest stage. Symptoms on one side of the body, minimal functional impairment. You're still living a pretty normal life. Stage 2, you start to have symptoms on both sides of the body. You don't have any balance issues yet. Stage 3, that's characterized by the loss of balance. Stage 4, it's becoming a severe disability for you, but still able to stand and walk without assistance. By stage 5, the individual is confined to a bed or a wheelchair. So it is degenerative. It is sad. It does make the patient angry because they see this happening. Diagnosis has to be done by a neurologist. It involves a process of elimination. What happened is a physician usually administers carbidopa, levodopa, which is a drug, to check the patient response. If the symptoms get better after being administered this medication, then they're positive for Parkinson's disease because that combination of drugs is used to treat Parkinson's. So obviously, if you see an improvement, that's one way that the process of elimination is carried out. Treatment, As far as drugs, there's dopamine replacements, levodopa, dopamine uptake inhibitors, anticholinergic drugs. There's non-motor symptom regulators such as antidepressants, anti-anxieties. As we said, those are necessary because you do see depression and anxiety in this group. Some non-drug-based treatment, deep-based stimulation. There's also the placement of this carbidopa-levodopa suspension in the small intestine. And what it does is it releases this into the system at a predictably slow rate, consistent rate, and you don't have these ups and downs in how the drug is going to interact with your system. You don't have times when you're real low on your medication or times when it's really kicking because you're high on it, the high end of it. This is a pretty good way to do it because it keeps things leveled out. Deep brain stimulation is something else that is done. It's the preferred surgical method of treatment. The goal of this is to reduce tremors and motor fluctuations, dyskinesia, and the need for medications. FDA approves deep brain stimulation to work on dystonia by working on the globus pallidus interna. I'm not going to ask you that. To work on bradykinesia and tremors, you're looking at the subthalamic nucleus. And then if you're looking at just tremors, ventral intermediate nucleus. Specific areas where deep brain stimulation takes place. The suspension we talked about, again, it's placed in the small intestine. It's continuously pumped for up to 16 hours. It's reserved for people who have advanced Parkinson's disease, minimizes the amount of off time experienced with oral medications. There's times when, drugs have a half-life and things like that. And there's times when you're at a low amount of drug in your system. This cuts down on this off time that's there. Now there are some side effects, and we're talking about sedation, this orthostatic hypotension, where you have low blood pressure depending on the position of the body, hallucinations even, and progressive weakness can be seen. So I just noted that there's a lot of side effects from some of the medication and treatments that are done. So that's one of the precautions during exercise. Also, we know that there's instability and abnormalities in the gait depending on how advanced the patient is. Fatigue is a huge issue, and this orthostatic hypotension. If you don't understand that, take a little time and look it up. Barriers to exercise for this population, people with Parkinson's disease. Depression, number one. Wouldn't you be depressed? All of a sudden your hands are shaking. You can't do the things you wanted to do. You can't walk the way you did. You're not as independent as you once were. You fell down yesterday. You've never done that before. Heck yeah, you'd be depressed. Discomfort with activity. Sometimes it can be kind of painful. Tightness in the chest. Lack of time. There's that one again. That's basically there with every group. Fear of falling. And a belief that exercise won't benefit those with Parkinson's disease. Not true. Just saying. Benefits of exercise. Now note this top one, improved, and this next part is my favorite part, or at least maintained muscular strength, muscular endurance, flexibility, and balance. Sometimes our goal is not to add 20 pounds to someone's bench press. Sometimes we want to work with patients to help them maintain the ability to brush their own teeth or to be able to walk from their home out to the vehicle. If we can keep them there for longer, then we're doing our job. Another thing that we need to work on is the prevention of bone loss. That is a benefit. We know that exercise can promote bone formation. Skills development is something else. If they're having trouble doing things, they can improve their skills through doing exercise, especially directed exercise that is helps to train them in the area where they're having deficits. This runs right into my therapeutic recreation background. Targeted exercise can help develop skills, period. Neuroplasticity, let's talk about this. You need to know what this word means. It's the ability of the brain to adapt and form new neuronal connections when stimulated by mental and physical challenges. It happens also following injury or disease. So neuroplasticity, it results from increased blood flow to the brain, greater production of neuron growth factors, an increased number of synapses where our impulses meet, and improved immune system functioning. This is a positive thing we're talking about here. As far as exercise testing, need to work with the client's physician, physical therapist, whoever else is working with them as a healthcare professional to develop a safe, effective exercise program. ACSM recommends for this group a cardiovascular risk assessment to be done, since a lot of people who've had Parkinson's disease, they're going to be older and they've been inactive. We also need to do assessments regarding balance, gait, and mobility to see where they stand. That helps us to decide what sort of activities, exercises are safe for these individuals. For testing, submax cardiovascular testing with a stationary bike is a good thing to do. If they don't have balance problems, then a treadmill walking test is okay. You want to measure functional ability with functional reach test, tandem stance, single leg stance, tug, or sit to stand. We're looking to see if, you're checking for things like flexibility, balance, things like that. Test strength with 1 rep max or 10 repetition max testing if it's tolerated, but be prepared to use lighter weights than you may think that you're going to have to. Assess flexion and extension of neck, back, shoulders, elbows, hips, and the internal and external rotation of hips and shoulders. These all have to do with voluntary movements. They have to do with gait, how effectively they're able to walk. The goal of exercise here, we're talking about a debilitating disease that continues to get worse, basically. So the goal of exercise is to delay disability, prevent secondary complications associated with disease progression. So if we can keep them active, if we can work on cardiovascular health, then we can stay away from secondary complications such as, heart disease, things like that. We're also delaying disability by keeping their strength where they are, by keeping them able to walk as they are for longer. Most research supports the benefits of cardiovascular exercise there's been more research done about cardio exercise for this population. Resistance training is also helpful, factual right there. If you can keep their strength where it is, it's going to help them be able to do those activities of daily living for longer. Always want to get medical clearance and physician input. So here's some guidelines that we can kind of look at for people with Parkinson's disease. 5 to 10 minute low intensity warm up focuses on just limbering up. Avoid stretching because that can actually cause muscle tightening in this population. Avoid activity in a hot environment. It sometimes tends to make things worse. Encourage frequent rest periods and breaks. You don't want them to overexert. Suggest that clients participate in activity about 1 hour after medication administration. So if you can get on a schedule, and see them at a similar time and get that medication administration and your activity exercise, worked out on a schedule, that's the best. Make sure and encourage your clients to drink adequate fluids and obviously avoid floor hazards. Floor hazards, I mean, you can't have that in an exercise facility anyway. Somebody falls, especially in today's litigious society where everybody wants to sue everybody, I wouldn't have floor hazards in my exercise area. Cardio training, initially start with 5-minute sessions 3 times a week. Okay, that's very light, right? Progress to 30-minute sessions 3 times weekly. Your intensity needs to be at 12 to 13. I like the Borg scale. This is the RPE, rating of perceived exertion. You want them to be at 40% to 59% of the VO2, but 12 to 13 on a 6 to 20 Borg scale. You can see where that would be. 6 being not hard at all, 20 being as hard as you could take it. You want them just kind of midways. Water exercise may benefit those with balance issues. Take out the may and put does. Water exercise does benefit those with balance issues. It's kind of hard to fall in water. You've got buoyancy, hydrostatic pressure holding you up. They are able to do things in water that they're unable to do on land. That also helps to improve their mood and their self-concept. So positive right there. Resistance training, you want to do full body training twice a week. 1 exercise per major muscle group. Resistance that allows 8 to 12 reps, usually 40 to 50% of 1 repetition max. Allow 30 to 90 seconds in between sets. Rest for at least 48 hours in between sessions. Again, this is just something to take with you to use down the road. As far as flexibility training, perform static stretching 2 to 3 times per week. The key here now, perform static stretching 2 to 3 times a week following aerobic or strength training. A lot of times stretching prior to exercise can cause muscle tightness in people with Parkinson's disease. So it happens after aerobic or strength training. You limber up first, you warm up first, but you don't really do static stretching prior. Hold each stretch for 10 to 30 seconds. Repeat 2 to 4 times. Stretch all major muscle groups. Balance training. You want to do balance training, and this is something you actually want to incorporate with this population. Perform balance training 2 to 3 times a week for up to 30 minutes. Tai Chi is a very good option if you've never seen it. Might want to check it out. It's been shown to be particularly beneficial to those with Parkinson's disease. It's similar to yoga, Pilates. It's an Oriental-based type of slow, deliberate movement. It's also good for clearing your mind. It's that sort of yoga, Pilates kind of feel to it. If you haven't, you can check it out. Just pull up a YouTube video of Tai Chi. Facial and vocal exercises. Now we're looking at some very specific things here, and things that we wouldn't do with someone who has pregnancy or diabetes. But that's why we got to look at our patients, and why we have to know what's going on with someone who has Parkinson's disease. What do they need help with? How can we help them as an exercise professional? So we want to work on facial and vocal exercise. Encourage the client to make exaggerated facial expressions daily to keep their facial muscles active. Because if their facial muscles aren't active, use it or lose it. Before you know it, look like they've had 1 million Botox injections on their face, and they're not making facial expressions. So by having them do exaggerated facial expressions, and you're going to keep them able to do this for longer. Also, you want to suggest that the client can do things like count out loud or sing aloud to maintain voice projection. We talked about how the strength of the voice seems to deteriorate through time as it is degenerative. That's something else that is lost, is the voice. So have your client count out loud while they're exercising. Try to get them to sing out loud to maintain that voice projection. They don't even have to know that they're working on something. They could just be having fun. Do what you can do to help them to stay better and get better. So on to the sample exercise program. Again, not tested right here, but some things that you can do with them. And you need to look at this individually. Abdominal training, you can do things like seated abdominal squeezes, basic crunches, reverse crunches, seated lateral glides. Lower body training, again, sit to stand, wall squats, lunges, bridging, calf raises. If you have questions about what any of these are, with this being an online course, go to your book. They have pictures, explanations for every single one of these things. Upper body training, push-ups on the knees, back extension, lat pull downs, lateral shoulder raises, bicep curl on machines, and tricep extensions. These are all good upper body training choices. Balance exercise. If you don't know what these are, check it out. Tandem stance, single leg stance. Balance exercise, this would be something that would actually be fun for you guys, I would think, to have the opportunity to work with people with Parkinson's. This is not something you would be doing with all your patients. It would break up the monotony, give you a chance to work on balance with someone or vocalization with someone. I think that would be fun. So what does nutrition have to do with Parkinson's disease? Not much. In general, Parkinson's patients need to have a diet similar to the recommended diet for the general population. Do need to make sure that they have enough calcium and vitamin D, because osteoporosis risk is higher in this population, partially because they're older usually. Make sure they have an adequate fiber and water to prevent Parkinson's related constipation. That's relatively common. Consume small snacks regularly to ensure adequate caloric intake. You see people, as they are going through the degenerative phases, start to lose weight. You want to keep their weight up, keep their strength up by having them regularly have snacks at least. Take medications such as L-Dopa 30 minutes before or 30 minutes after consuming a protein-based meal. That's kind of beyond your scope. That's something that the physician, that the pharmacist should be telling the patients. And that is it for Parkinson's disease. And we've covered a lot this semester. I hope that you have learned some things. I hope you have watched some of these. I hope that you have enjoyed this information and found some things that you can take with you. And honestly, I did these videos for you guys to help you take something from this class. I really want you to. I know sometimes online courses are difficult, so I tried to give you another option for the ones of you who actually want to take some of this information forward and hopefully be able to apply it as you move forward. But I really enjoyed having you guys in the class, and I hope to see you in some more classes. Hang in there, stay safe, and I will see you guys later.